Let me share my screen. Okay, good evening, everyone. So nice to meet everyone. I'm a third-year fellow at USC and excited to talk with Nghiem about some of the emergencies that you commonly face in GI. This is, of course, not an extensive list, but I think it'll be fun to talk about some of the characteristic ones. And there are many people who are here who have significantly more experience, so please interrupt and weigh in at any time. All right, so, GI bleeding, let's see. GI bleeding, it's the most common reason for hospitalization, and it totals about 500,000 admissions annually, so it's a very common reason for bleeding, as is foreign body ingestion and food impaction. So we'll cover both of these topics in both case and non-case-based scenarios. Just a bit of an overview, for the bleeding side of it, it can originate in any part of the GI tract. It's called upper GI bleed if it starts in the esophagus, stomach, or small bowel. And the incidence of upper GI bleed is 6x that of lower GI bleed. So for the fellows on, especially the first year fellows, if you haven't realized this already, that's what most of the calls will be for. So let's take a case-based approach to reviewing guidelines behind upper GI bleeding management, because more than any other emergency, I feel this is what you get called about the most. Okay, so first we have a 65-year-old woman coming in with coffee ground emesis and pre-syncopal symptoms, has a past medical history of high cholesterol, rheumatoid arthritis, with the vitals that you see below, little tachycardic, hemoglobin below where it should be. So the first teaching point here is about immediate resuscitation efforts in someone with a likely upper GI bleed and hemodynamic instability. I'll be brief about this. I know everyone's probably intimately familiar with this, especially coming off of medicine residency, but resuscitative efforts are the first step in anyone with hemodynamic instability, even if you see them bleeding in front of you. It's an evidence-based recommendation that resuscitation leads to better and safer outcomes when you're scoping GI bleeder patients. So that's the reason why we wait and don't jump in sometimes. Make sure the patient has an 18-gauge peripheral IV access, give them fluids immediately. We like lactated ringers. In the ED, make sure you transfuse to hemoglobin of 7. And while these efforts are going on, you gain some more history from the patient. You realize that a little bit more. You realize that the patient has no prior surgeries, no illicit substance abuse, has never traveled outside the US. She does take some Aleve for the rheumatoid arthritis because there's joint pain associated with it. And this is, of course, a big hint as to what might be causing the reported coffee ground emesis. So we planned for endoscopy because the story is pretty convincing for an upper GI bleed. Guidelines recommend that non-variceal upper GI bleeds require an EGD within 24 hours. So when we actually scope will vary by day and by institution, and ultimately happens whenever the patient is adequately resuscitated. So while this is going on, what do we want to do for our patient, right? So it's listed up here. You want to give IV PPI for Shigan bolus with 80 and then do twice daily IV. Esomeprazole and pantoprazole are our choices in the US. PPIs, the reason we care is because they increase gastric pH and they stabilize the thrombus or thrombi. They promote ulcer healing because of that. You can also add on an octreotide IV drip. It's a splanchnic vasoconstrictor because we're not really sure about what the etiology of the bleeding is. And if it is something that could be coming from a vessel, you want to make sure you address that. And third, you can sometimes give promotility agents like erythromycin and Reglan, and that's just to make sure that we optimize our visualization when we do go in with an endoscopy. It'll clear the stomach of blood, and it'll just make life a lot easier when you're in there. Let's fast forward a few hours. We've done some resuscitation. You can see the current vitals are in green, and in many aspects have improved. She got all the medications we mentioned. So we're ready to scope. So we'll just jump to what we see. Zoomed in on the things that are most important. So what we see in front of us are a couple of ulcers, gastric ulcers. Actually, the most common cause of upper GI bleeding is peptic ulcer disease in either the stomach or the small intestine. And the most common causes are either H. pylori infection or NSAID use. The latter is what went on in this case because our patient was taking ibuprofen. So exactly what happens in both of these scenarios, whether it's H. pylori or NSAID use, is there's mucosal irritation or inflammation from either insult, which erodes the gastric mucosa until it hits an underlying vessel. Then that's affected, and then it starts bleeding to varying degrees. So we see two different ulcers. So let's talk about what we see and what it means. Like, what do we do? Is PPI enough? Do we do anything with it? And to answer this question, we have to describe the ulcer with the Forest system, Forest classification rather. Basically, it categorizes ulcers based on their appearance. And the whole point, like, why do we do this? It's not arbitrary. The point of doing this is that there's certain features of an ulcer that are correlated to the chance of it rebleeding if you don't intervene. And therefore, it tells us the risk benefit of intervening, and it tells us if we should intervene based on what we see. So there's 6 classifications. I think it's easiest to remember that they're in 3 groups that you can see in the columns in front of you. So there's groups 1, 2, and 3. Group 1 is acute hemorrhage. You see bleeding in front of you right now. 1A is the most severe. You can see just like column of blood shooting out. 1B shows active bruising. Group 2 is the in-between thing. They show, these ulcers show signs of recent hemorrhage, even though they're not actively bleeding. 2A shows a vessel. 2B has an adherent clot on top of it. And 2C has a flat pigmented spot. And group 3 is it's just one type of ulcer. It's clean-based, the least severe. Each of these 6 categories correlate to risk of rebleeding. And you can see that listed underneath the description for each. You can see why, right? So like if you look at Forest 3, at a rebleeding risk of like 4%, probably doesn't need intervention. It'll be fine with the medications that you're giving, especially the IV PPI. However, the other ulcer, and let me go back. So you can see one of ours is Forest 3, but the one on the right is Forest 1B. That has a 50% chance of rebleeding if left alone. So we need to do something. For all the other ulcer types, take a look at group 2B. I have found that 2B, half of my attendings will intervene and half will not. And I think it often depends, it's a case-by-case thing, so it's not a hard and fast rule, depending on just what else you see, what else is going on with the patient. Anything more severe than that, you should intervene. Anything less severe, you might be able to just watch. But again, there is some variation based on the patient at hand. So we have to intervene on ours. Listed the rebleeding rates right there. So what do we do to intervene? We have 3 choices. We have injection therapy, thermal therapy, and endoscopic clips. Some of the details are outlined there. So injection, you never use this alone. That's like really, really important. Probably like the top 2 or 3 things I'll say. Do not use it alone. It is a temporizing measure. The injection itself, it's almost always epinephrine in a 1 to 10,000 or a 1 to 20,000 ratio with saline. The saline itself can actually cause some local tamponade, which I thought was interesting. More potently, epinephrine's vasoconstriction will temporarily slow or stop bleeding, and that's the utility of using it. It helps slow down bleeding temporarily, so it'll clear the field so you can do other interventions more easily, because as you can imagine, it's hard to intervene on something that's gushing in your field of view. So the next part of therapy, thermal therapy or hemoclips are both definitive therapies. They can be used alone. Injection has to be used with something else. So thermal therapy, thermal coagulation with contact probes or gold probes. What it does is you place pressure on the culprit vessel to compress it while the coagulation is performed. This ends up sealing the vessel. And then the alternative is argon plasma coagulation or APC. Here you actually do not directly touch the mucosa. It sprays argon gas from the probe tip that touches the tungsten tip of that probe. And then the argon ionizes and wants to ground at the nearest tissue. And hopefully that's the tissue, that's like the ulcer tissue or the ulcer edge tissue. So if we use a probe immediately adjacent to where we want to intervene, but not touching it, thermal energy is delivered. It goes 2 to 3 millimeters deep into the mucosa, and it leads to both linear and tangential coagulation. Finally, we can use clips. There's so many brands and so many sizes that I will not get into, but the main tenet of hemoclip use is that the jaws of the clip, they need to be embedded in healthy tissue, extending beyond the diameter of the ulcer ideally, so that when the clip is closed and then later deployed, the ulcer edges are brought together, or opposed is the term that you'll hear. So unlike thermal tools, the clips don't cause inflammation or acute tissue injury upon being applied. But the negative part is, unlike thermal tools, you do have to have really good visualization of the entire lesion you want to intervene on to make sure that you're putting things in at the right angle. And fortunately for us, we did all this with our patient and hemostasis was achieved, which is great. So, because there was at least one ulcer with high-risk stigmata, it's important to continue the IV PPI for a total of 72 hours. You get that call like, hey, you fixed it. Can we send this patient home? The answer is no. Had there been no higher stigmata, you could have changed to just an oral PPI, which now the patient can be given on discharge. There was no vascular cause of bleeding. Remember, there's no like, and what I mean by that is there was nothing that was part of the portal system that was bleeding. So you can discontinue the octreotide while the patient is inpatient. And the last teaching point for this case is cancer can also cause ulcers. You know, just because you're taking NSAIDs doesn't mean you don't also have another pathology. Sometimes, like up to in some studies, say actually 6% of these ulcers can be caused by some type of malignancy. So if you see gastric ulcers like we did in this case, you have to repeat an EGD after 8 weeks on PPI to reassure ourselves that it was just H. pylori, it was just the NSAIDs, and that's why the PPI has completely resolved it with normal mucosa. Because if that's not the case, and there is an underlying malignancy that caused either one of the ulcers here, we will see evidence of it, or we'll see a lack of resolution. So then we can continue intervening or diagnosing rather. If these were duodenal ulcers, that's not really the case. With duodenal ulcers, 99.5% of ulcers are really from benign causes, so it's not standard practice to go back in. That being said, you know, a comprehensive clinical picture is up to your judgment. The clinician's judgment, I think, supersedes everything. If something looks odd, if something looks weird, you can always go back in because it's in the best interest of the patient. So going on to our second case, we have a 50-year-old man comes in with witnessed hematemesis, which is a big deal. I know, like, a lot of us have gotten the pages of hematemesis, and it's like, who saw it? What was it? But this time it was witnessed in the ED. It's a 50-year-old gentleman. He has ETOH-associated cirrhosis, MEL25, Child's B because of hepatic encephalopathy, had an ACL repair a decade ago. Otherwise, pretty unremarkable past medical history. You can see the vitals in front of you. And this is somebody you would be concerned about if you got called. The story is he was at home this morning, threw up dark with clots, and then it started getting red. And that's when he decided to come in, which was a good move. And the hemoglobin is down from his baseline, 2 points drop. And the map is fluctuating in the low 50s. So here, the GI bleeding is overt and witnessed, and it's upper GI bleed because it's red and coming through the mouth. There's a concern that it's active and not just old, given the progression of first coffee ground to now hematemesis. And just remember, it takes like 50 cc's of blood in the stomach to cause melena. So not that much, but it takes like 100 cc's, maybe closer to 150. I've seen different reports to cause hematemesis. So this gives us some benchmark as to the volume of bleeding that's going on. You know, the differential for hematemesis is pretty broad, including peptic ulcer disease, which we just reviewed, variceal bleed, trauma or ingestion, Mallory-Weiss tear, PhD, vascular malformations, it goes on. But the first thing to rule out or address in a patient like this, I think, is a variceal bleed because it has like the highest mortality rate. They can quickly decompensate. These variceal bleeds end up happening in cirrhosis patients, which are already disadvantaged health-wise in many other ways. You want to catch them before they decompensate because it can happen very fast. And the reason this happens in these folks is cirrhosis, you know, intrinsically involves a parenchymal change in liver tissue. That leads to an increase in portal pressure, which manifests in many things, but it also manifests in dilated esophageal varices that are more prone to bleeding because of that. So for this patient, because the hematemesis was witnessed in large volume, he was appropriately intubated in the ED for airway protection. You know, it's the middle of the night, of course, because that's when these things happen. And you as the on-call GI fellow get called, and they have two questions for you. They first ask like, hey, they're like, this person was throwing up buckets of blood before we intubated. Should we, you know, the hemoglobin is 7.3, but should we just keep giving blood because maybe he's losing a lot? The second question is, when can you scope? So the answers. Again, clinical judgment isn't in front of everything else, and you can make a judgment as to how accurate you think a certain hemoglobin is, so I won't go into that, but I just want to make the point that the transfusion goal in these bleeders is still 7. Transfusing beyond this goal can sometimes actually worsen bleeding because it'll increase intravascular volume, increasing portal pressure, and then mounting bleeding will increase. And then, of course, when should we scope? Variability in scope time depends on so many things, as you guys know, that are not always medical. That holds here as well. But because this is one of the sick types of patients you'll see guidelines saying that you need to scope a person within 12 hours if you suspect acute variceal hemorrhage. I want to make that point. I will make an aside, which is if you need to buy some time and you are worried about this or they need to be resuscitated in other ways, you can consider a tamponade as a temporizing measure, a balloon tamponade. So I won't spend too much time on it, but I just want people to know, because I remember learning this in real time for a sick patient. You can place a balloon somewhere in the patient's esophagus or stomach, depending on which of these three devices you use, for the sake of just tamponade, holding things down while you figure other things out with the patient. It's temporary hemostasis while other things are being optimized. It's not definitive or permanent. There's 3 types: the Blakemore, the Minnesota, which is similar to the Blakemore, but also has an esophageal suction port, and the Linton, which just has 1 balloon. So they all have different numbers of balloons and ports. I've used the Linton like 4 or 5 times, but I haven't used the other ones. So the theory behind all 3 is generally you insert the tube into the patient's mouth and inflate the balloon or balloons. And on the other end of the tube that's going out of the mouth, it's attached to some type of counterweight and hung at an angle. This makes the balloon flush against the gastric and or esophageal mucosa with the pressure that tamponades potentially bleeding varices. Depending on the tamponade option, the absolute max it can be left in for is 48 hours. So I will say that anecdotally, we have not wanted to exceed 24 hours, and often significantly sooner than that, you want to take them out. And this is because the devices cause pressure necrosis over time, right? That can evolve into perforation, especially the esophageal mucosa is not used to holding things for a long amount of time. So this patient got a Linton in the ED while the map stabilized. It's the next morning, a few hours later, in the endoscopy suite, and you're ready to scope. In the meantime, just like the other case, you've done all those other helpful things: PPI, octreotide, erythromycin, or Reglan. So you deflate the balloon, take out the Linton, start the EGD, and you find the following things, which is a lot. So this is a bleeding varix. You can look on the left-sided picture. You don't need me to tell you this. This is obviously bleeding, and this is a big cause of why you saw the hematemesis. I wanted to point out that you might run into the other things, the middle photo and the right side photo. It's not active bleeding, but you see signs of recent hemorrhage. The middle one, the white nipple sign, it's a platelet fibrin plug that shows that something might have just bled or recently bled. And on the right side is a red whale sign. It's a longitudinal red streak on a varix. It's named that because it's named after this type of like corduroy pant, red striped pant. So now how do we address the bleeding varix, which is definitely the cause of the hematemesis? So the mainstay, there's 2 big mainstays. Overwhelmingly, you want to use something called endoscopic variceal ligation, EVL, or just banding. There's also endoscopic sclerotherapy. So banding, or EVL, involves sectioning a mucosa where the bleeding is occurring and placing a small elastic band around it. If there's a site of active hemorrhage or recent hemorrhage, the band will be placed over that mucosa. So something to note about banding is that anything proximal to the band, i.e. closer to the mouth, will decrease in pressure. And anything distal to the band, i.e. closer to the stomach, will increase in pressure. Therefore, the general goal is to place the bands as distal as possible, so the longest or largest amount of varices can have a drop in pressure and therefore not bleed. And again, if you see something that's bleeding in front of you, it doesn't matter if it's more proximal, you have to band it. This is the banding tool. There's just know that you can deploy up to 6 most of the time, depending on the brand, and that the second to last one is a different color to let you know they're almost done. And then sclerotherapy. It's quite simple. You just use a needle to inject a sclerosing solution into areas that are bleeding or might have recently bled. This is particularly helpful when you can't tell where the active bleeding is coming from. You can inject in the areas of suspicion, or sometimes seemingly at random if you go and you can't see anything, and place and inject rather. Of course, it's possible that injecting into an area might affect how difficult it is to section up mucosa, especially later on, but this is an emergency situation, so it doesn't really matter. I'll also say that trials from around 1995 showed around 90% success in hemostasis in variceal bleeder patients using one or both of these methods. Also wanted to point out there's backup plans if it doesn't work. Esophageal stent, TIPS, surgery. I won't go into detail because of time, but I'll point out that TIPS is something that you can consider in patients with gastric varices with high-risk stigmata because it can be difficult to band, especially if there's also esophageal varices. So you're kind of damned if you do, damned if you don't. And the image on the bottom left, I just want people to know, especially first years, that gastric varices are described based on their location, and that helps tell us what we can intervene on in what way. Okay, so fortunately, banding worked in this patient, stopped the IV PPI, continued the octreotide for 72 hours. And when you discharge this patient, there's a couple things, or in the future, you have to consider a couple things. Now this is a cirrhosis patient who's had a hemorrhage history. So at some point you have to start carvedilol, depending on how stable they are. And he'll also need a repeat EGD in about 2 weeks to see if your intervention has now diverted blood flow into other veins or varices that are now at high risk of bleeding. So they might come back in a couple of weeks with some other columns of varices that might not be bleeding, but you still have to place bands on them. You keep repeating that until they're done. Okay. The last thing I wanted to talk about is not really case-based, just foreign body ingestions and food impactions. An overview. 95% of the time, foreign body ingestions are accidental. And when this is the case, it's food. It's like bones or toothpicks in food. And 85% of the foreign body ingestions pass on their own, which I know feels surprising to fellows who get called about the ones that do not pass. And this is, the remaining 15% is where we feel we can help. There are some people who are at higher risk of getting a foreign body ingestion, and the risk factors are listed on the right side. Older, intoxicated in some way, if you have a psychiatric condition. And then if you just have morphologically some pathology in your esophagus that changes the shape of it and makes it more likely to catch food. Pill ingestion isn't really a cause, pills don't really get stuck as much as that's a symptom that people talk about for other pathologies. Also, in incarcerated populations, think of internal concealment of illicit substances as a possibility as well when they come in with symptoms you're not really sure what the cause is. Fortunately, surgery is only needed in like 1% of the cases. And then site. The most common place for something to get stuck is the esophagus, like in the whole tract is the esophagus. And there are 3 places that are high risk, and that's just anatomy. The upper esophageal sphincter, of course, things can contract. There's other like pharynx, larynx, everything is up there. There's a part of your esophagus where it starts going left and crosses the aortic arch, and that's a little bit of narrowing in that area, so things can get stuck there. And finally, where the diaphragm is for, again, understandable reasons. And foreign body ingestion might be how you discover someone's achalasia or cancer. So clinical symptoms are actually really important to recognize, especially as the on-call fellow. Acute dysphagia is a big one. Choking, drooling, pain in the retrosternum, not able to manage secretions, regurgitating undigested food. Drooling and like not being able to manage your own secretions is actually a really big deal. They're particularly concerning because it means nothing is going through the esophagus, not even a small amount of saliva. So you might have that ingestion causing a complete esophageal obstruction, and then it's like very time sensitive. Depending on when the patient presents, they might have actually had this ingestion, not like 2 hours ago, but possibly 2 days ago. It might be quite some time. And the reason that is important is if it's been some time, they might have a higher chance of these complications listed on the right. And some of these complications have more particular symptoms that I hope will kind of like ring bells in your head if you hear it. So perforation, that's bad. So these patients might have like neck pain, or the neck might be red or swollen, dysphonia, even crepitus in this area from cervical subcutaneous emphysema. Tachypnea, fever, shock are also possible, but that's an alarm sign in itself, so you wouldn't worry about that necessarily. You wouldn't miss that, rather. Obstruction symptoms, what I mentioned before, is for when it's in the esophagus, but if it's in the small bowel, you'll have like SBO type symptoms. And then if you have a fistula, if it's with the aorta, that's a problem which we'll talk about. You might start off with a bleed. And if it's with the trachea, cyanosis, cough. So let's assume that the patient doesn't have any of these crazier signs of esophageal obstruction that you're thinking about. That means you have time to image. And this is where the history is really important. Ask a patient what they swallowed, when they swallowed it. If it's from the history, it seems like the item is radiopaque, or if you're not sure, you can consider a plain film because they're easy and fast. They do have some limitations because they won't capture bones, wood, plastic, like thin metal oriented in certain ways, glass, food. When you do get a plain film, do AP and lateral views, as you can see in the middle column of images. In addition to identifying an object, the plain films are important in determining where it is in relation to certain airway landmarks. You can see the coin and trachea and coin and esophagus are 2 different things, because coin and trachea is something ENT can help us with, and it's not something we would safely be able to retrieve. And again, like if you look at the tracheal foreign body, they align on the sagittal plane and they're best seen on a lateral projection. So it's best to get 2 views. Disc batteries are differentiated by having a double shadow or a stack of coins, and then coins in the esophagus are best seen in the AP view. And you can also see some complications on plain film. You can see free air, hydrothorax, pneumothorax. Use CTs for the following indications. If you think there's a perforation, if you think there's a necrotics packet or something really sharp and pointy, it has great sensitivity and specificity for detecting objects in the esophagus. And it's a better characterization of other complications if you suspect that's what's going on. And then the timing, I mentioned this before, emergent is like do it right now. Definitely within 6 hours, but as soon as you can. Complete esophageal obstruction, disc batteries, anything sharp and pointy. And then urgent or within a day is anything in the esophagus, like you can't just leave it there. And then certain things in the stomach, which I'll get into. Magnets, sharp and pointy, that's rule of thumb, and anything greater than 5 centimeters. And I just included that photo there because I think it's insane that you can swallow glasses. So for the stomach, there's some special rules that I feel like we keep getting tested on and are clinically relevant as well. Like, will it pass? You see something in the stomach, you're like, it made it through the esophagus. Like, will it make it through the stomach? A couple of rules. Most things will pass in 4 days or less. Here are exceptions. If the diameter of the object is greater than 2.5 centimeters, it's probably not going to pass through the pylorus. So that's like concern number one. Concern number two is if you have like a long, thin object, if it's longer than 5 or 6 centimeters, it's probably not going to make it past the sweep. So even if it's day one, if you see objects that exceed those parameters, there's not really any point in you wasting your time waiting 4 days to see if it will pass, because it probably won't. And if you have cylindrical or disc batteries, if they haven't moved in 1 day, they're not going to move generally. So just take them out. And for everyone else, you can do like weekly plain films, daily plain films if they're inpatient for another reason, or if you just want to follow them more frequently. You can escalate care if there's no progression or if there are alarm symptoms. Specific endoscopy concerns, there's so many scenarios that we're not going to cover them all for ingested items rather. Like one person's chicken meat experience is different from somebody else's, but there's a few general tenets. A big thing is airway protection. Airway protection is so big. You have to intubate to prevent aspiration. You don't want to drop something in their lungs. You can also use an overtube during endoscopy to protect the airway when you're removing objects or several objects out, so you don't scratch the mucosa or drop it into the airway. Endoscopic tools vary, but a few are listed there. And then finishing the scope isn't the end of the workup. We have to understand why something got stuck in a certain place. Sometimes it's obvious, like the glasses, if they got stuck somewhere, I wouldn't be surprised because they shouldn't normally pass. But smaller objects, or especially food, if that wasn't an issue before, it might be that first signal that there's an underlying pathology that we don't know about. But that's all I had. We'll move over to the lower GI emergency section. Thank you guys for your attention. Stop share.
Thanks, Rika. Let me go ahead and share my screen. That was awesome. Hi, everyone. So my name is Nghiem. I am a fourth-year GI fellow at UCSF. Briefly, I did my internal medicine residency at UCSF. I short-tracked me to GI. So doing my research here now, and then next year will be transplant hepatology, also at UCSF. So it's my pleasure and privilege to kind of talk to you briefly about lower GI bleed. And I kind of tailored this talk really towards their earlier fellows, just kind of give you the framework and how to manage these, especially during when you get PH. And for the senior fellows, so hopefully it's a reminder. So briefly, lower GI bleed, it's about 20% of all GI bleed cases. Usually it's the hospital admissions, invasive diagnostic evaluation, consumes a pretty significant medical resource. Although most people with lower GI bleed they stop bleeding spontaneously, have favorable outcomes. They are associated with morbidity and mortality, especially in the older population. They classically present with sudden onset hematochezia, maroon or red stool. However, in rare cases, they do also present melena, and these are your proximal colon bleeds, similar to kind of what other upper GI sources that Rika kind of mentioned. We definitely want to keep that in mind, given that 10 to 15% upper GI bleed do present as lower GI bleed. And for this talk, I mainly focus on the ACG guidelines, and I was hoping that a new one would be available by now, but if not, it's currently in process. So hopefully it's ready by 2022 with Dr. Straight. It's been really important to recognize that there's a steady increase of lower GI bleed compared to the decrease of upper GI bleed, especially in older populations. And furthermore, the increase in burden and the cost of lower GI bleed is really accounting for up to 370,000 1,000 ED visits each year, resulting to 144,000 hospitalizations. And it's really the fifth most common cause of GI cause for ED presentations. So our patient, we got a page for the fellows on call. We got a 72-year-old man with coronary artery disease on aspirin, type 2 diabetes, hypertension, hyperlipidemia. Presented really acute 3-hour bright red blood per rectum, some lightheadedness, hypotensive, tachycardia, and a hemoglobin drop of about 3 points. They say, please help. So, in terms of the management and evaluation for the ACG recommendations, they definitely, we're all really, we're recent residents and now we're current fellows, and some of the times I think that the biggest thing is really just assess the patient, talk to the patient, and really gather histories. And most of the histories that you obtain will really kind of narrow down your differentials. And with like the lower GI bleed compared to upper, the differential is not that big. They recommend a couple of risk stratification in terms of score. I just listed here because for academics of it, just kind of inform the fellows that there are scores available. But to be honest, I think that most of us don't really use this as really our general gestalt. You have a patient who's hypotensive, tachycardic, you're not going to discharge that patient. And I think that's what their take-home points are. But let's talk about these scores briefly. So Oakland score, it's really for low-risk patients. And these are patients who it's helpful to maybe decide when to scope. It's okay to be discharged from the ED in terms of resource utilization and do outpatient endoscopy. So I think that's helpful. You can see that the score of less than 8 is pretty good for safe discharge. For our patient, his score is 33. For age, sex, as well as his heart rate, his blood pressure, and his hemoglobin. So definitely by all means, he's not going to go. He's going to be admitted. And then, now thinking about the high risk, there's two. The straight score, it's really focused on the severity of bleeding. Like, is likelihood of the patients to have severe bleeding or not? And for our patient, is 6. He's hypotensive, tachycardic, he's non-cardiac abdomen, he has bleeding recently, aspirin use, comorbidity. So his risk for bleeding is quite high, about 84%. The next score that's available is the ABC score. A stands for age, B is blood tests, as well as C is comorbidities. And for our patient is 2. So I think that, if we use the score, he's a high risk for severe bleed with low mortality and definitely not able to be discharged. So I think the score is there for you to use to risk stratify, but I think a lot of it is really evaluate the patient yourself and get a history. So differential, really the chunk of the differential is really diverticular bleed. It takes 30 to 60% of the chunk, followed by ischemic colitis, hemorrhoids, and then ends up with inflammatory as well as infectious etiology. So you can understand that when you see the patient and we're assessing them, and you know that there's a history of maybe a previous scope, that diverticular imaging, previous diverticular bleed, we can increase it. If the patient in the ICU, we get the consult and they're on triple pressors, it's most likely ischemic. And if they're there for acute bloody stools with constitutional signs, then most likely infection. So a lot of the differentials narrowed down by just the history that we take. So for our case, he's hypotensive, tachycardic, and we found out that he has a history of diverticulosis on a surveillance colonoscopy back in 2018. So that increases our likelihood of diverticular bleed. Luckily, he has no prior GI bleed, no history of abdominal surgery, so we're not concerned for any complications of recent procedures. His hemoglobin, he's not infected, no constitutional leukocytosis. His BUN creatinine ratio is it's about 1. So this kind of tells back to Rika's point where this is part out like upper GI bleed source. And in terms of his liver enzymes are quite unremarkable, so no concern for maybe a burst upper GI bleed like a variancy that Rika mentioned about. So in terms of management, I won't belabor this point, but I agree with Rika's 100%. The first thing is resuscitation. And I think that I just wanted to put these figure up or the highlight in terms of the millimeters per minute in terms of resuscitation. I think a lot of the times when we're fellows, we ask for access, they say 2 IVs, but we really want to care about the IVs just in case things are about to crash. And we definitely want about 18 to 16 gauge that Rika kind of mentioned because of the milliliter per minute rate. It's amazing. It's 100 to 200. So you can do FTP through. And then a lot of times they say that we have a central lumen or central catheter. But if you think about the catheter, the largest lumen is 52 milliliters per minute. So that's not sufficient by all means. So by all means, get 18 gauge available for your patients. And so management option for lower GI bleed, there's only three. Really, us, colonoscopy, radiology, our colleagues, and surgery. Colonoscopy, radiology can definitely localize, treat, as well as diagnose. Surgery, we'll talk a little briefly at the end, but by all means, it's kind of the last resort. And they can really just treat. They depend on us to localize. So back to ACG management, they recommend colonoscopy as the initial tool. We agree with that. And bowel prep is really to make sure that the bowel is adequately prepped so I actually get good visualization. Now, for the fellows on, I think that this is something that's going to be changing in an updated guidelines 2022, and I'll share you some data. But the urgency, I think that, we get paged usually, again, like we just said, nothing ever happens good at night. So we get called around like 5 p.m. as the way we're leaving the hospital or in the middle of the night. And now we have to make a decision. Do we scope early or do we prep? And then do we scope tomorrow? And I think that hopefully we leave away from this talk. Hopefully you get some evidence and understand that maybe it's not just all go. So urgent timing, a long time ago, they kind of mentioned most of this data was based on upper GI bleeds. Of course, your patient coming in, they're bleeding, you see blood, they're hemodynamic state, but you want to get in. But maybe the time of day may not be the right ideal, especially a lower GI bleed when you can't see, you can't do anything. So the pros are diagnosed to treat. Maybe you can triage the lower risk patient. Maybe it's a hemorrhoidal bleed. You can let them go home without being admitted. So there are some pros for urgency, but then the cons are under resuscitation, which is never good. Inadequate colon prep because we can't see. And a lot of it, what we face is inadequate support staff, especially in the weekends or late at night. And then we have to use the OR or ICUs. So there's the first study back in 2000, this is the earlier one, by Dr. Jensen, they saw about 121 patients with severe hematopoiesia. And then they looked at the patients who had a colonoscopy within 6 to 12 hours. And you can see, it's pretty convincing. Like you have these 6 to 12 hour preps and they decrease the amount of additional bleeding, severe bleeding, transfusion parameters, as well as the time on hospitalization. So I think when this came out, a lot of the thought was like, did we scope early? We forget about the logistics part. We want to do right by the patient. So, this was a small study and this was done, I think this is the UCLA group. And so there was concern for generalization. So we had a meta-analysis about 2 years ago, looking at now 2 RCTs, 10 single arm, 9 observation. And if you look at the forest plots, the urgent colonoscopy didn't really lead to improved rebleeding rates, mortality rates, as well as length of stay. There was some maybe concern that maybe urgency is not always the right way to go. But we need an RCT, we need a bigger one. And here came the biggest one. In 2000, in a Red Journal, in Gastro, they saw 170 patients in Japan. Patients they randomized with less than 24 to greater than 24. And again, they didn't see any risk of our outcomes that we care about, like hemorrhage, rebleeding rates, transfusion, and mortality. So again, this question is urgency versus non-urgent, maybe not so important. And I think that what really hit the nail on the head or nail in the coffin is really this big meta-analysis that was done again 2 years ago, looking at 4 RCTs now, 463 patients, looking at less than 24 hours to greater than 24 hours. And the relative risk did not change for any of the outcomes that we care about. Bleeding, stigmata bleeding, as well as surgery or mortality. So I think it's pretty safe to say that if we get these consults, I think that the best thing we can do for our colleagues who are asking for us help is really help them resuscitate, talk it through, make sure we get good access. And then for us to really look at the story, make sure we're not missing the upper GI bleed. But in terms of the lower GI bleed, get the patient stable and then prep them. And I'll share you algorithm, a very short algorithm later during the talk. But say we need an urgent colonoscopy, some of the prep that I just wanted the fellows to know is you really had to get that go lightly in. 1 liter for every 30 to 45 minutes, and they can't tolerate the NG2. I know it's not ideal, but it's the only way to really make sure we have a good bowel cleanse. So the case continued. He received 3 units. Hemoglobin responded, improved hemodynamics, and then he continues to still pass more clots. And now we're prepping him. So for endoscopy management, back to the guidelines, they do recommend us treating everything that we see that are considered high risk. And this is similar to the forest classification that Rika kind of mentioned, but And I'll share you the next slide what they are. They recommend clips and flow thermal energy for different types of diverticular bleeding, which I'll clarify, as well as use of epinephrine injection, but they get similar to upper GI bleed that Rika mentioned, definitely not the only, epinephrine should never be used alone. And then, so the stigmata, the high risk, similar to the forest classification. I think that some of the fellows, I feel like I scope maybe 25 diverticular bleed, I maybe down to 3. They're like the unicorns. So I think that, you know, some of the things I want to highlight on the active bleed in the left corner, these have a rebleeding rate of about 67%. So you see it, you treat it, of course. Sometimes you have a adherent clot, the rebleeding rate is 43%. You still want to treat that. And sometimes you see this non-bleeding vessel in the dome, and you definitely want to treat that. And I'll show you how to. So I think that this guy had diverticular bleed, and I think for fellows, it's really important to understand why we administer certain therapies, and it goes back to anatomy, right? Diverticular format really is sites where the vasa recta penetrates the muscular wall. The arterial is really displaced over the dome, and then diverticular bleeding is either the base of the dome or the neck. And I think it's really important to understand these are bilateral flows. So what that means is if you have a diverticular bleed at the base of the dome, you definitely want to clip both sides. And clipping on one side is not going to fix everything. And you can see on this anatomy picture, just very thin wall, no muscle layer. So thermal energy in the base diverticular or dome may not be the best option. Again, some more pictures to highlight for the fellows, given that these are sometimes hard to see. But you have the A is the bleeding, B is when the diverticular dome is inverted with a cap, and then C and D are also diverticular dome bleeds. So when you see this, you know, it's hard because sometimes you go in there, there's 20 diverticula, you just gotta wash it, take your time, and make sure we treat it, or else you get a call back later in the day for the patient's rebleeding again. So these are kind of what we talked about, the schematic of things. If you see a diverticular bleed, you're lucky to find one, and you're about to intervene on, you wanna make sure it's a base or the neck. If it's the base, it's usually non-bleeding vessel because that's where the vessels are. And you want to make sure that we clip both sides. Again, the bilateral direction flow. I think sometimes initially we clip one and we call it A, but really you want to make sure you clip on both ends. If it's a neck bleed, sometimes epinephrine injection is helpful, just because again, more visualization, clear to feel that we kind of mentioned. And then now you can either use two things. You can use thermal energy, which is safe now because it's a muscular wall rather than a dome, or you can place a clip. So there's two other techniques I want to share with the fellows on, and you know I haven't had a lucky chance to mind treatment. My treatment is always gonorrhea as well as clips, but you know I always use a cap. That's the one thing. Cap for improved visualization to peel back the flow, especially when you're going to knowing that you're treating as a therapeutic scope. But what you could do is sometimes when the dome is so deep and then you see a little vessel, what you could do is suck out the dome. And when you suck out the dome with the cap, you can do the same procedure that I shared with you last time, where you clip either directly onto or you clip from both sides. The other thing that they do a lot in Asia is band ligation. I would love to try this one day, but again, with the cap, it's similar to kind of Rika shared with their soft tube varicose. You use a band, you suck it up, kind of similar to the band and cap technique. Once you get it into your field, you place a cap around it, and that sort of kind of cuts off both bidirectional flow, and it's actually pretty good in Asia. I haven't seen this done here. But those are kind of techniques that you can use in your arsenal as a fellow when you go in there, now understanding the stigmata, and then now how to approach it depending on location of that bleed. Going back to lower GI bleed management strategies, you know, I think that say we can't fix it with endoscopy, you can't find it. You know, there's also non-colonoscopy interventions, and this can be radiology colleagues. We have three. I just want to briefly share to you in terms of the bleeding rate. TEG RBC scans, yes, they can detect the most slow bleed, but if you can imagine, it's very time consuming. You need medicine available, and they have a lot of false positive. Angiography, again, I think that would be ideal, but unless you're 100% sure it's a diverticular bleed, and IR is going to be expecting the patient to go through this is pretty invasive with a lot of complications like embolization, ischemia, arrhythmias because of the with the medications used, as well as artery injury. So we go to CTA. CTA, look at the sensitivity and specificity you can detect, you can localize, And then for the fellows on, when you order a CTA, don't just go to sleep and go from there. You might get a call back and say it's positive, and that's when you really want to help your medicine colleagues or hospital medicine colleagues by reaching IR and really getting the IR to recognize it. And most of the time they are aware, but the time from positive CT angio to time of actual intervention is super important. You want that less than 90 minutes, or else afterwards you may not be as useful. So again, I think I'm waiting for the new guidelines to release in 2022, but Dr. Straight did simplify her guidelines for 2016, which is quite complex. But she's wanted us to know that you want to see a patient, there's low risk, they're stable. You do a colonoscopy, you can't do it, and you rebleed again, CT angio, and you treat the stigmata. The high risk patient, unstable patients, you resuscitate them, they're still bleeding, they're in ICU, they're in pressors. There's no point of you prepping and then doing the colonoscopy. You want to get straight to CTA. And then if they're even worse and they can't handle it, they just call IR, and then IR is standby for CTA, and then afterwards embolization. Surgery, by all means, we talked about before, is a last ditch effort. We want to do everything we can to avoid this. But then indication for surgery is really failed medical, endoscopic, radiographical. They require maybe a lot of transfusion, like MTP, molasses transfusion, and you cannot stabilize them. Then surgery would be the only route. Briefly, given for sake of time for the fellows on, I just want to round out some of the more common causes of lower GI bleed. AVMs are quite fun to treat when you see them, and you use argon, or you can place it above, but they look like this, where it's almost like a spirally wet. And then you have the ischemic colitis. The story kind of tells you sort of everything in the ICU on multiple pressors. Most of the time, it's conservative management as well as starting antibiotics that we can recommend. But if they really want us to go in and make sure that it's not CMV or not something that we can intervene on, then of course we can quickly take a quick look. But there is a risk for perforations, and we could stabilize with topical hemostasis agent like a hemospray. So the hemospray is quite good. This trial showed that hemostasis was achieved 98% of patients with monotherapy, combination therapy, rescue therapy alone, with an acceptable bleed rate. So again, this is the arsenal that hopefully most of the fellowships have by now, and you guys are familiar using this one. Post-polypectomy bleeds are other ones that is the rounds of the top 6. Really just it's delayed sometimes with hot stare. Now we're kind of moving towards cold stare, EMR. Hopefully that, and then also placement of clips on the right side, so hopefully we don't have that many post-polypectomy bleed. And really treatment for this is really hemoclip or thermal with epinephrine plus or minus. Other lower causes of GI bleed, rounding up inflammatory bowel disease. For you guys to know, it's really common, more common in UC, but then more severe in Crohn's, given that it's transmural. Radiation proctitis can happen anytime between months to a year. NSAIDs are lovely medication, can cause both upper and lower, and neoplasm as well. But neoplasm usually kind of acutely and not massively. So in summary, I think that based on just sort of the guidelines and I guess whenever you get a page for lower GI bleed, you want to evaluate, you want to resuscitate properly, like Rika mentioned, for upper GI bleed, while rolling the upper GI bleed, and then taking your time and to really narrow down your differential while the patient gets stabilized. You want a colonoscopy, not urgent, it's not needed. Hopefully 2022 guidelines will come out and clarify that, because then the current guidelines are now say still less than 24 hours. You want to use a cap. So for the fellows here, using a cap is great for not only upper GI weights, variants that are really treating various, but you also want to use it for the lower. We don't use this often, so make sure you bring a cap to the ICU when you're doing the CAR view. And then understanding how to fix the diverticular bleed depending on location. If it's the base, make sure you clip both sides. If it's the neck, you can use epinephrine as well as cautery or a clip over. Management, again, I think that depending on the severity of the patient, if you have a concern on pressure, they can't resuscitate, get IR and surgery involved early. Thinking that just for backup, and then make sure when you do radiology, CT angio is the preference. RBC tag is not ideal, and then the take-home point is the angiography has to follow within 90 minutes for us to make it useful if you detect something on a CT angio. And lastly, surgery. Nobody wants to do this, but it's really our last resort if we can't fix it ourselves. But yeah, that concludes our top or upper and lower GI. Thanks for staying, and I'm so sorry. I was hoping to get you guys out earlier. But yeah, well, up to question. There's one question from audience. If this is cirrhotic, this is for Rika. If the cirrhotic patient's heart rate is 3, do you prescribe carvedilol?
That's a good question. I don't know. Other people can weigh in. Like, I think for coreg specifically, like if your heart rate fall is consistently below 55, at least when you use it for hypertension or other indications, you're supposed to do a dose reduction. I think if they're stable and they're living at that number, you should just start at 3.125 mgs and then see what happens. For anybody else, you want to titrate to like mid to low 60s heart rate. But I think in this patient, this is somebody who already bled. So they're at high risk of having a decompensation event from cirrhosis. I don't think 3.125 milligrams of coreg is going to tip them over. If it is, they have other issues going on. So I would start it. Close monitoring though.
And one thing from Rika's slide, I think after the banding, you definitely want, I think we stopped the IV PPI, but you definitely want to keep the PPI on for at least 14 days to prevent post-banding ulcers. Also known, not sure.
Now look at Michael's.
Oh, okay, sorry. I was like, this is a question I probably can't answer. But yeah, any other questions from the current fellows and the attendees on? Thank you so much for joining. Have you come across ticks that we are able to assess the tools? Yeah, it's a great question. I think that this is where the CAP came in. I think that, so one of my mentors here, Dr. Colin African, she's the one that really uses that a lot. I think sometimes when this is the issue, when the diverticulum is huge, you actually can go in. That's easy. The problem is when they're small, and you see that some vessel or maybe some overlying clot. I think that's when the cap and suction will invert it would really help. And then to answer your question, if I can't treat it, what I do, if I can mention this, and for the fellows on, I think this is really helpful. If you know that there's a site there, even though you can't treat it, even if you do treat it, you worry about rebleeding, just place a clip adjacent to it. Your radiology colleagues will love you for it. And also, if you are thinking that this patient is unstable to go to surgery, then tattooing adjacent contralateral, I usually fix the diverticular, place a clip adjacent to it just in case, and that way, if anything were to happen, we can go straight to IR. So hopefully that answered your question. And then is there a sweet spot for pro-motility agents in large and moderate upper? There is. I love pro-motility agents, even on lower GI. I believe when I'm prepping the patients as well, it just helps move things along. And I also use pro-motility agents when I use a capsule as well, but you want to give it about 30 minutes ahead of time. So I think that usually times for the fellows on when you're running to the ICU, this is really helpful. I mean, we don't do it for outpatient, but you're setting up the cart. Make sure you call the ICU team or the medicine team, or you place the order yourself, and just call and give them the erythromycin now. And by the time your cart's up, you just set it up, then you're good to go.
And it won't, like, when it wears off, it's not like the blood will come back. So, like, well, it can, but not a lot.
But yeah, I think that's all. And it's 7 o'clock already. So thanks for joining us. Again, taking your time out of your busy day to just hang out with us. I really appreciate it.
Thanks, everyone.
Good job, Rita.